Mhm. Hi, good night. Name is Dr. Brandon Ruben from San Fernando General Hospital, and tonight I'll be presenting cranial and paraspinal nerve tumors. Firstly, objectives. We'll define cranial and paraspinal nerve sheath tumors with emphasis on schwannomas, neurofibromas, and malignant variants. We'll differentiate between tumor types based on clinical, radiological, and pathological features. Understand the genome, the genetic and syndromic associations, such as NF1 and 2 schwannomatosis Carney complex. Outline the current treatment modalities, including surgical approaches, radiosurgery, and surveillance strategies, and discuss the prognostic factors and complications associated with various tumor subtypes. Firstly, a definition where these tumors are benign, slow-growing neoplasms composed of one or more elements of a nerve cell, whether it be a Schwann cell, perineural cell, fibroblast, mast cell, ganglion cells, myxoid or collagenous matrix, and axons, and they may occur sporadically or part of a syndromic condition such as NF1 and 2, schwannomatosis, or Carney complex. First off, schwannoma, which are globular, circumscribed, and encapsulated benign nerve sheath tumor composed of well-differentiated Schwann cells. They are one of the most common peripheral nerve tumors. 90% are solitary, but can be multiple in the setting of neurofibromatosis type 2, which makes up 40% of cases. 8% makes up 8% of all intracranial tumors, 85% of CPA tumors, and 30% of spinal nerve root tumors. There are no gender predilection noted for this tumor. Multiple can occur in neurofibromatosis too, with bilateral involvement of the vestibular division of cranial nerve 8 and schwannomatosis. Spinal schwannomas typical in NF1, where tumors takes up a dumbbell-shaped, and they most commonly arise in the peripheral nerves and skin and subcutaneous tissue of various areas. Intracranially, it involves the vestibular division of cranial nerve 8, where they are known as vestibular schwannoma, but can arise from other cranial nerves. A mosaic pattern of SMARCB1 iron 1 expression is seen in 93% of familial schwannomatosis, 55% of sporadic schwannomatosis, and 83% of NF2 associated schwannomatosis, and only 5% of solitary sporadic schwannomas. Histologically, most are biphasic, with 8 in the A and B tissues. They make up a peak incidence in the 4 to 6 decades of life. Clinical presentation depends on location and type of involved nerve, and incidental detection is common, especially in the peripherally situated schwannomas. For example, vestibular cochlear nerve or trigeminal nerve may present with insidious onset of hearing loss or trigeminal neuralgia, respectively. If resected completely, schwannomas usually do not reoccur. However, incomplete resection can lead to slow regrowth. Gross total resection is often difficult with cellular and plexiform subtypes. Radiation therapy, including ablative radiotherapy such as gamma knife radiosurgery and cyberknife radiotherapy, has been used to treat residual tumors or tumors not amenable to surgery. There is no effective chemotherapy, but bevacizumab has been used with mixed response. Malignant transformation of these tumors is exceedingly rare. Focusing now on vestibular schwannoma, which is the benign tumor of cranial nerve 8 located in the CPA. It's the most common non-malignant nerve sheath tumor, which makes up 8 to 10% of cases and makes up 80% of CPA tumors. There are 3.3 to 5.2 per 100,000 persons per year. The incidence was also found to increase with age, with one study identifying a rate of 20.6 per 100,000 persons per year among patients over the age of 70. 90% of these tumors are unilateral, with incidence increase of NF2, with bilateral involvement being a hallmark. Symptoms commonly present of a triad of symptoms, which includes insidious and progressive ipsilateral sensorineural hearing loss, high-pitched tinnitus, and disequilibrium, with true vertigo being uncommon. Typically symptomatic after the age of 30, where larger tumors can cause facial numbness, weakness, or twitching, and possibly brainstem symptoms. Rarely hydrocephalus is caused. Cranial nerve 8 symptoms makes up the triad, the most common triad of symptoms, which is the insidious progressive ipsilateral sensorineural hearing loss, high-pitched tinnitus, and disequilibrium. Cranial nerve 5 and 7 gives you otalgia, facial numbness and weakness, and taste changes can occur as the tumor enlarges and compresses the fifth and seventh nerves. They only occur once the tumor greater than 2 centimeters. Brainstem and other cranial nerve symptoms can have ataxia, headaches, nausea, vomiting, diplopia, cerebral signs, and if unchecked, coma, respiratory depression, and death. And other lower cranial nerve palsies can be present. Obstruction of CSF can be caused by larger tumors, which is usually greater than 4 centimeters and may produce hydrocephalus with increased ICP. Rarely, 6 cranial nerve involvement may cause diplopia. This diagram shows the most common symptoms in vestibular schwannoma and the percentage occurrence, with the most common being the triad of hearing loss, tinnitus, dizziness, and imbalance. Signs: since hearing loss is sensorineural, Weber will lateralize to the uninvolved side. If enough hearing is preserved, Rein's test is positive on both sides. Cranial nerve 7 dysfunction is uncommon before treatment, with vestibular involvement causing nystagmus. Diagram here shows the both Weber and Rein's test, which the Weber test goes to the uninvolved side. And this diagram here shows vestibular schwannoma, the signs of it, where the most common one, excluding the hearing loss, being abnormal corneal reflex, nystagmus, and facial hypoesthesia. Evaluation: MRI, brain with contrast, and navigation and ISC protocols used, and the Coos classification to grade tumor size is used. Temporal bone CT if surgery is contemplated, and audiometric evaluation. Pure tone audiogram, which may be useful as a first step screening test. Air conduction assesses the entire system. Bone conduction assesses the cochlea and proximally. Pure tone audiogram assesses the functionality of the hearing to help in treatment decision making and acts as a baseline for future comparison. Speech discrimination evaluation is maintained in conducing hearing loss and moderately impaired in cochlear hearing loss and worse with retrocochlear lesions. It's no longer used for diagnostic purposes. Sorry. Patients with small vestibular schwannoma, which is less than 1.5 centimeter, certain other specialized hearing or audiometric evaluation can be used, such as ENG, which stands for electron nystagmography, which only tests the horizontal semicircular canal and assesses the superior vestibular nerve that innervates it. Vestibular evoked myogenic potential, VEMP, which assesses the inferior vestibular nerve by imparting acoustic energy to the saccule, independent of hearing, and can be done even in deafness from profound sensorineural hearing loss. And finally, ABR, which stands for auditory brainstem responses, is useful for prognostication. Poor wave morphology correlates with a lower chance of preserving hearing, even with good hearing. Image here shows the Clues classification for the vestibular schwannomas, with grade 1 being intracanaliculated tumor, grade 2, tumor that extends into the CPA but does not extend into the brainstem, grade 3, tumor that occupies the CP sustain and contacts the brainstem but does not displace it, and grade 4, tumor that displaces the brainstem and cranial nerves. MRI images demonstrates a right cerebellopontine angle mass that shows diffuse enhancement with contrast. Note that the mass arises within the right internal auditory meatus, causing its widening. It's compressing the right side of the pons and brachium pontis. It is associated with surrounding peritumoral cysts. Another set of images, MRI, shows a axial T2, which shows a heterogeneous hypointense mass in the right internal auditory canal and CP angle cystine. B axial shows a homogeneous hypointense mass. And C, the axial diffusion weighted image, shows a heterogeneous isointense mass. On image D, you have the axial T1 pre-contrast image, which shows a heterogeneous isointense mass, with E being the axial T1, the post-contrast image, which shows heterogeneous but evenly enhancing mass. And F is the coronal T1 post-contrast, which shows a heterogeneous but evenly enhancing mass. Expectant management, symptoms, hearing, and tumor growth. Serial imaging is monitored. These are monitored by serial imaging. Intervention is only performed for progression with growth patterns such as little or no growth, slow growth, which is 2 millimeter per year, and rapid growth greater than or equal to 10 millimeter per year. Radiation therapy can be radiation alone or in conjunction with surgery. External beam radiotherapy, stereotactic radiation, or stereotactic radiosurgery with single dose less than 13 grays for hearing preservation and minimize new or worsening cranial nerve deficits. Surgery, surgical management of vestibular schwannoma should take into account the tumor size and morphology at the time of diagnosis, as well as the patient's symptoms, comorbidities, and preference. Large vestibular schwannomas, whose grade 4, surgery may be considered as a primary treatment to remove symptomatic or potentially threatening mass effect. Surgery may be considered for smaller tumors if cystic degeneration is present or if cure is a primary goal of treatment. Probability of hearing preservation in patients with normal hearing was greater than 50 to 75% immediately after treatment as well as after 2 and 5 years, and greater than 25 to 50% after 10 years. Goal of surgery should have total or near total resection, since residual tumor volume correlates with the rate of reoccurrence. For larger vestibular schwannomas, the lower risk of recurrence after gross total resection should be weighed against the higher risk for facial nerve dysfunction and lower rates of hearing preservation, since there seems to be a relationship between the tumor volume and functional outcome. In a 2008 study by Seol et al., 116 patients with VS were treated with gross total resection, near total resection, and subtotal resection. This yielded recurrent rates of 3.8%, 9.4%, and 27.6% respectively. In a more recent study in 2016 done by Jacob et al. Of 103 sporadic VS patients who underwent near total resection or subtotal resection. Those with subtotal resection experienced recurrences 13 times more than those treated with a near total resection. For large VS, the lower risk of reoccurrence should be weighted against the higher risk of facial nerve dysfunction and lower rates of hearing preservation, since there seems to be a relationship between the tumor volume and functional outcome. For these cases, partial resection followed by SRS has become increasingly popular. With this combined approach, the results reported so far show superior outcome regarding facial nerve function and hearing preservation when compared to total resection, with comparable tumor control rates. However, studies are still small and retrospective, and in VS recurrent after surgery, radiosurgery may be used preferentially because of the risk of damage to the facial nerve is lower than that of a second operation. Surgery approaches have the retrosigmoid or suboccipital, which may be able to spare hearing. Translabyrinthine approach sacrifices hearing, but may be slightly better for sparing cranial nerve 7. And middle fossa approach, which is extradural subtemporal, only used for small lateral vestibular schwannomas. This image shows the general location and entry point of the suboccipital approach in 1, translabyrinthine approach in 2, and middle fossa approach in 3. Management of vestibular schwannomas grouped into different groups. Small tumors, less than 15 millimeters, with perfect hearing. We do serial imaging and hearing tests every 6 months for 2 years after diagnosis, then if stable, annually, 5 years after diagnosis, and then if stable at years 7, 9, and 14 after diagnosis. Treatment is recommended if growth greater than 2 millimeters between studies. Small tumors, less than 15 millimeters, with serviceable hearing, but have a 50% chance of preserving their serviceable hearing with either observation, SRS, or microsurgical resection. Observation is strongly recommended as initial management. Hearing preservation rates better than 50% have been reported for microsurgery and radiosurgery in selected patients. Smaller tumors located medial in the ISC, intact pre-op ABR amplitudes and latencies. Final management decisions are often dictated by non-medical reasons, whether it be patient perception, social situation, financial considerations, or support systems. Medium tumor size, 15 to 25 millimeter diameter. These are treated in young patients with close observation and option for elderly patients and patients with comorbidities. In NF2, early management is considered more favorable for good outcome. Large tumors greater than 25 millimeters, microsurgical resection favored to reduce mass effect and decompress brainstem. SRS more useful in larger tumors for older patients with significant comorbidities. For tumors greater than 3 centimeters, maximal P fossa dimension with brainstem compression, intra-op nerve monitoring of trigeminal nerves, lower cranial nerves, and use of SSEPs is not obligatory, but should be considered. For tumors greater than 3 centimeter diameter with symptomatic hydrocephalus, pre-op placement of EVD is optional. A VP shunt should be placed if the hydrocephalus does not resolve post-op. This image shows an algorithm of the different management compared to the tumor sizes and the recommendations for each different stage of monitoring. Next is the neurofibroma, which is the most common peripheral nerve sheath tumor. These are benign neoplasm composed of neoplastic Schwann cells interspaced with normal cells. They are located commonly in the dermal layer of skin and may involve deeper nerves of a nerve plexus or major nerve trunk. Diagnosis essential: infiltrative low cellularity spindle cell neoplasm associated with a variable myxoid to collagenous stroma and mixed cell population, and desirable factors listed below. Neurofibroma, they are sporadic and solitary. Multiple lesions can occur in the context of NF1 and may appear between ages of 5 to 10 years. Plexiform lesions are usually congenital. The clinical presentation of these localized intraneural fibromas are nonspecific and the result of either mass effect on surrounding lesions or palpable lump or neurogenic dysfunction. Cutaneous lesions are soft, mobile, and asymptomatic, with deep tumors produce sensory and or motor symptoms related to the nerve of origin. Least common, plaque-like cutaneous and subcutaneous mass of head or neck, or a massive enlargement of the shoulder or pelvis, which are common in NF1 patients. CT scan shows a well-defined mass with minimal or no contrast enhancement. MRI is hypodense in T1, and hypertense and target sign can be seen on T2. Image here shows a T2 weighted axial MRI that shows a well-defined round lesion in the right neural foramen or paraspinal space. The lesion is hypertense peripherally and relatively hypointense centrally, producing the classic target sign, a radiographic feature commonly associated with benign peripheral nerve sheath tumors, particularly neurofibromas. Another MRI images here, which shows a well-defined extradural extramedullary lesion seen along the posterior lateral aspect of the cervical spinal canal, displacing the spinal cord anteriorly. The lesion appears hyperintense on T2 weighted image, and a central hyperintense area consistent with the target sign, which are characteristic of the neurofibromas. Lesion may extend into the neural foramen, giving a dumbbell-shaped appearance, not fully seen in the slice, but often present with nerve sheath tumors. There are intermediate signal of on T1 with moderate contrast enhancement and high signal on the T2. Most pronounced at T2 at C2 with the cause marked cord compression. The spinal cord is displaced and mildly compressed, but no overt myelomalacia clearly seen in the image. Vertebral bodies intervertebral. This shows no significant abnormalities. For NF1 type lesions, these are localized and diffuse and may be treated surgically. As neurofibromas infiltrate between the nerve fascicles, they are unable to be separated from the parent nerve, and complete excision requires sacrifice of the nerve. Deep-seated tumors are managed conservatively, with local reoccurrence uncommon and malignant transformation rare. For NF1-associated lesions, due to multiple lesions, unless symptoms debilitating, treatment is conservative. Plexiform are difficult to resect with incomplete resection, commonly owing to frequent reoccurrence. Plexiform demonstrate potential for malignant transformation. Prognosis: the isolated cutaneous neurofibromas are usually benign, with the plexiform and ANUBPs and intraneural lesions, which may progress to malignant peripheral nerve sheath tumors. Perineurioma. These are benign tumors comprised of neoplastic perineal cell exclusively. Primary treatment is surgical resection. With benign perineuriomas, complete surgical removal curative with a low risk of recurrence. Malignant perineuriomas, surgery is the primary treatment, but recurrence can occur. Intraneural and soft tissue perineuriomas rarely occur and metastasize. Malignant perineural tumors with high mitotic activity have a poor prognosis and can spread distantly. Diagnosis is essential for soft tissue perineurioma. What is essential is slender spindle cells with bipolar cytoplasmic processes and storiform and/or whorled architecture, and tumor cells positive for at least one perineural antigen and negative for S100. For the intraneural part subtype, it is essential to have pseudo-onion ball pattern on a cross-section with axons in the center, and tumor cell positive for at least one perineural antigen and negative for S100. Images here, MRI shows a 18-year-old female that has an intraneural perineurioma, with the T1 weighted image. On the left demonstrates an elongated mass, which is the black arrow, superior to the subclavian artery, which is a right arrow in the location of the right brachial plexus divisions. Stir image on the right shows increased signal along a segmentally enlarged brachial plexus component, which is a white arrow. Another image shows the axial fat-stranded gadolinium enhanced T1 weighted image, which demonstrates a homogeneous enhancement within the lesion. Next, hybrid nerve sheath tumors, aka benign peripheral nerve sheath tumors. These are generally rare, with tumors showing a hybrid morphology of either schwannoma perineurioma or neurofibroma schwannoma. These are found in a wide age range, but seem to have a peak in young adult. Clinically, these lesions in the subcutaneous tissue and skin often manifest as painless mass, whereas lesions in the spinal nerves and larger peripheral nerves can present with pain and neurological deficits. Prognosis, these rarely occur following excision. For the diagnosis, it is essential to have intermingled features with two types of benign nerve sheath tumors and appropriate immunohistochemical staining for each component. Images here shows a 75-year-old female that presented with right leg cramps, sagittal T1 weighted image, and axial T2 weighted image show a well-defined lobular lesions expanding and remodeling to the right S1 ventral nerve root. The features are consistent with benign peripheral nerve sheath tumor, histologically confirmed schwannoma perineurioma. Next, malignant melanotic nerve sheath tumor, also known as malignant melanotic Schwannian tumor. These are peripheral nerve sheath tumors comprised of neoplastic cells with both Schwann and melanotic features that frequently behave aggressively. They usually arise from spinal or autonomic nerves and loss of PRKAR1A protein expression with PRKAR1A gene mutation, which suggests links to Carney complex. For diagnosis, it is essential to have a fascicular to sheet-like proliferation, variably pigmented, relatively uniform, plump, and spindle to epithelioid cells, and either co-expression of S100 SOX10 and melanocytic markers, or loss of PRKAR1A expression or PRKAR1A mutation, and methylation profile of malignant melanotic nerve sheath tumor. These tumors are rare and sporadic cases with a mean age of 33.2 years and Carney complex with a mean age of 22 years. Approximately 50% of cases are associated with Carney complex. Characteristic molecular findings are combined genetic inactivation of NF1, CDKN2A or CDKN2B, and SUZ12 or EED genes, as well as complex genomic rearrangements. They are asymptomatic presentations have been noted in 29% of cases, with surgical resection the treatment of choice. Adjuvant radiotherapy can be considered in cases showing histological criteria for malignancies, incomplete surgical resection, tumor reoccurrence, or metastases. Stereotactic spine radiosurgery can be used for spinal tumors, where the prognosis is usually unpredictable, with 26 to around 44%, which may occur locally or metastasize. Images on A shows a CT scan, which demonstrates a well-defined petrous lacuna image. Image B, T1 weighted image, which shows a hyperintense round lesion centered on the right Meckel cavum, relying on the intrapetrous carotid artery and generating a mass effect on the temporal lobe. Image D, to the bottom left, diffusion weighted image is negative. Going across the image E, which is a T2 weighted image that shows the presence of cystic areas. C and F are axial and coronal T1 weighted image, which shows a slightly heterogeneous enhancement after contrast administration. Moving on to malignant peripheral nerve sheath tumors. These typically originate from a peripheral nerve, a pre-existing benign nerve sheath tumor, or in a patient with NF1. 50% are associated with NF1, with plexiform neurofibroma, a common precursor of lesions with NF1. Patients with NF1 have an 80-30 in lifetime risk of developing malignant peripheral nerve sheath tumor. These may spread along the nerves and 20% metastasize hematogenously, usually to the lung. They have a 20 to 50 age range. In children, usually associated with NF1, where the mean age is less than 10 years in sporadic cases, can arise in virtually any anatomic location. Most common sites are the trunk and extremities, followed by head and neck. Images here shows what is essential for diagnosis: histopathological, consistent malignant cell tumor in a patient with NF1 or in a pre-existing neurofibroma, or malignant spindle cell tumor associated with peripheral nerve, no more than focal or patchy S100 SOX10 expression, and SS18, SSX, SSX2, or 4 fusion gene present, or malignant spindle cell tumor associated with the peripheral nerve and evidence of PRC2 inactivation, molecularly or via loss of H3, PK28ME3, immunostaining, or tumor with features associated with ANNUBP in a patient with NF1, but with a mitotic count of at least 1.5 to 4.5 mitosis per millimeter squared, or unresolved lesion with a methylation profile of malignant peripheral nerve sheath tumor. Management of these tumors: aggressive surgical resection, followed by radiation therapy to achieve local control. Prognosis: you have a favorable prognosis, but it depends on factors such as small tumor size, male gender, no metastases at presentation, gross total resection, and epithelioid and perineural subtypes. Image here. On MRI, you have features such as surrounding peritumoral edema, regular, and or locally invasive margins, and intratumoral heterogeneity appear. These coronal T2-weighted MRI of the brain demonstrate a large heterogeneous mass located in the left skull base region, extended into the infratemporal fossa. Key imaging features which suggest a malignant peripheral nerve sheath tumor includes heterogeneous signal intensity with both hyperintense and hypointense components, irregular lobulated margins, contrasting the more circumscribed appearance of benign nerve sheath tumors, mass effect with displacement of adjacent structures, including the temporal lobe and possibly brainstem structures, and perilesional edema and possibly bone remodeling or erosion. Finally, cauda equina neuroendocrine tumor, formerly known as cauda endocrine paraganglioma. These are neuroendocrine tumor which originates from specialized neural crest cells in the cauda equina. CSF protein is usually increased, commonly present with common features of lower back pain and radiculopathy, and less commonly numbness, paraparesis, sphincter disturbance, increased ICP, or symptoms of cauda equina syndrome. Diagnosis: either well-demarcated tumor with Zellbellen architecture and synaptophysin or chromatogranin immunoradioactivity in chief cells, and cauda equina location, and for unresolved lesions, methylation profile of cauda equina neuroendocrine tumor. Diagnosis may be made preoperatively, showing serpiginous dilated and ectatic blood vessels, which may have a positive CAP sign. They are well-differentiated, uniform, round, or polygonal chief type 1 cells, which congregate in lobules encompassed by a barely discernible single layer of sustentacular type 2 cells. Complete microsurgical resection remains the first choice of treatment, where the prognosis, they are slow growing and have a low recurrence rate following gross total resection. Images on the left shows a large intradural mass which occupies much of the lumbar canal below the tip of the conus, with evidence of bone remodeling. A slightly hyperintense on T2 weighted image and isointense to quadrant T1 with a very large flow void. Mass is associated with very large serpiginous flow voids, both related to the mass as well as on the surface of the conus. Finally, summary and key takeaways. Schwannomas are the most common benign cranial nerve tumors, often involving cranial nerve 8, with management tailored based on size and symptoms and patient factors. Vestibular schwannomas, hearing preservation is central to management decisions. Small tumors may be observed, while large ones may need surgery plus or minus radiation. Neurofibromas are more infiltrative and associated with NF1, and plexiform variants carry risk of malignant transformation. Malignant peripheral nerve sheath tumor and malignant melanotic nerve sheath tumor are rare but aggressive tumors and require early detection and aggressive multimodal therapy. Surgical decision-making should always balance tumor control, cranial nerve function preservation, and patient quality of life. These are my references, and thank you.